Hey guys, Miss Hill here, and back talking with you about sexuality, the concept of sexuality. This is individual module 4 and PowerPoint 1, lecture number 2. So we're finishing up the second half of PowerPoint 1. And we left off at health promotion. So let's pick up there. All right, so what does health promotion mean? And we talked about this earlier in the semester. So in a very simple term, it's a healthy lifestyle and promoting that healthy lifestyle. So a healthy lifestyle from a sexuality standpoint will reduce the risk of sexual dysfunctions that are related to acute or chronic illnesses. Also reduces the risk of needing medications that can impair your sexual functioning. So for example, if we live a healthy lifestyle, we eat healthy, we do some exercise, we might avoid hypertension in the later parts of our life. And if we can avoid that, we can avoid blood pressure medicines that go along with hypertension, and we know blood pressure medicines can impair sexual functioning. So that's just one very simple example of how leading a healthy lifestyle can reduce your risk as an individual of having sexual dysfunctions later in life, or at all, hopefully. Cancer screening for women that specifically would relate to sexuality are things like cervical cancer screening and mammograms once you hit 40 years old. For men, those cancer screenings include screening the prostate once a man becomes at least 50 and possibly earlier. Another big thing from a health promotion standpoint are vaccines against the human papillomavirus or HPV infection. HPV is a nasty little virus that can be transmitted sexually. You can be infected as a male or a female, and it can cause cancer at a young age or an older age if you contract HPV from a partner, particularly certain types of HPV. There are many, many types of HPV. So routine immunization is actually recommended starting at around age 11 or 12, because the key is to get this vaccine prior to ever becoming sexually active. And if you can get this vaccine prior to becoming sexually active, it is almost 100% effective at preventing cancers against those types of HPV. And because sexual behaviors and sexual experiences now are happening younger and younger and younger than they were decades before now, it's important to get these vaccinations early. So screenings that are related to hypercholesterolemia, hypertension, those are important because those types of things can alter perfusion. We know a lot of older adults have problems with high blood pressure and high cholesterol. And whenever you have diseases that alter your perfusion, that can affect your sexual health. Back to the HPV vaccines. There are 3 types of HPV vaccines at this point in time. There is Gardasil, Gardasil 9, and Cervarix. They are all given over a 6-month period by an IM injection. And most of them will protect, well, they all protect nearly at 100% as in terms of their efficacy. We try to give them, like I said, before the client is sexually active, because these vaccines will only protect you against new cases of HPV that are contracted. They will, if you already have a case of HPV and then you get the vaccine, it will not protect you against the strain that you contracted before you got the vaccine. Gardasil particularly protects against cervical cancer, genital warts, cancer of the anus, vagina, and vulva. And it is approved for males and females 9 to 26 years old. The thought is that the research has proven that it lasts at least 8 years. Gardasil 9 protects against the same thing as the regular Gardasil, but it includes 5 additional types of the HPV in terms of protection. It can be used in males that are ages 9 to 15 years old and females 9 to 26. It's a fairly new one, so we're not quite sure what the duration of its efficacy is right now. Cervarix, on the other hand, protects against only the types of HPV that cause cervical cancer. So it's only approved for females who are ages 9 to 25 years old. My slide doesn't want to turn. Okay, here we go. Another big part of health promotion are safer sex practices and being able to teach those, particularly as a nurse. And a setting where you might encounter having to do this will be at a primary care pediatrician office, health department specifically. And safer sex practices include things like limiting your number of sexual partners, preferably staying mutually monogamous with your partner. Hey, Earl, will you go gun blast in there? I know, I'm sorry. I gotta do my lecture. Okay? Those gun blasts are really loud. Please. Well, then go in there and shut the door, or you go in there and shut the door. Okay? Take the dog with you. I learned a long time ago, y'all, that these lectures aren't perfect, and I just have to roll with it. So I hope you get a giggle out of it every now and again. So no unprotected sex, especially if the partner that you are sexually involved with has an HIV status that is unknown. It is important to get HIV testing whenever you enter into a new relationship, and this is especially true for young adults who are at college. I mean, it's especially true for everybody. But in my mind, I think about college students that are at a really great risk for this. College students and young adults who are starting new relationships. Latex condoms for any type of sexual activity that has to do with oral, vaginal, or anal intercourse. For vaginal or anal intercourse, lubricating the condom with non-oxyl 9, which is a spermicide, can prevent pregnancy. Engaging in practices that are less potentially damaging to sensitive tissues are also part of practicing safer sex. So mutual masturbation and avoiding anal or oral sex, which can damage those tissues and lead to sexual dysfunction problems in the future. Not engaging in drugs or alcohol, sharing of needles, razors, or toothbrushes, sex toys with other people. Yeah, your charger's up there on the counter. And no unprotected sexual activity if one partner is HIV positive. On that counter, under the poster, yes, right there. Plug it in. So no unprotected sexual activity if one partner is HIV positive, meaning if you're in a relationship, one person is HIV positive and you are not, you should be using protection 100% of the time. And then HIV positive women should take steps to try and prevent pregnancy unless they are at a point they are ready to have children. They need to consult with a physician for some preconception counseling. Another safer sex practice that is probably not as well known or thought of is something called pre-exposure prophylaxis, or PrEP. It is very highly effective at preventing HIV if it's used as prescribed. So this is a pill that can be taken to prevent contracting HIV, but it has to be taken at least 7 days before the protection actually occurs in the body. And then it has to be taken every day after that as prescribed for as long as the person wants that protection. The brand name of this pre-exposure prophylaxis drug is called Truvada. And it is very commonly prescribed and taken by homosexual men. All right, so now we're into the nursing process as it relates to the concept of sexuality. And always you should be doing an interview before you do a physical exam with somebody. That gives you the opportunity to establish a therapeutic relationship where there's some mutual respect between the nurse and the client. The client feels not judged, and they are willing to open up to you so that you can truly help them with what problems they are there for, or possibly you can help educate them on risks that you discover throughout that interview. So interviewing really should precede the physical exam. In terms of men, we want to talk about the current problem. When did the problem happen? And have them describe the problem for us, and have them talk about medications or remedies that they have tried that may work or may have not worked. You always want to gather a medical history because we want to know what types of chronic diseases or past illnesses or surgeries that the patient has had that would contribute to any types of sexual dysfunction. And then obviously psychosocial history, so tobacco, alcohol, drugs, stress in their life, what their sexual history is included, particularly as it relates to sexually transmitted infections. All of those things will contribute to interventions and education that we might choose to do. So during the assessment, when we're from a lifespan standpoint, nurses really should ask teenagers directly what they know about sex, contraception, and reproduction. Providing factual information about sex acts, and their consequences, and the individual's right to make decisions regarding their personal sexual expression and the responsibilities that each individual has with respect to sexual activity is very important for adolescents. And some of those things are very important just in general across the lifespan. For women, we really want to know the same types of things regarding their current problem, but we want to talk about when their last menstrual period happened. In terms of medical history, things that are a little different here than men have to do with their menstrual history, their obstetrical history, and then under the psychosocial history, any types of birth control that they might be on. Whenever it comes time to do the physical assessment that involves genitalia, it is extremely important to keep a professional approach so that you can reduce the anxiety of your patient. Being non-judgmental, very gentle in your touch, and empathetic is extremely important because this is a very intimate part of people's body, and they are oftentimes very uncomfortable with other individuals that they are not in an intimate relationship looking or feeling around in those areas. So you have to be very cautious about how you perform those physical assessments. You want to make sure you avoid any misperception that you could be sexually harassing or abusing the patient. So always having a second person in the room with you as a witness, touching them in a fashion that is non-intimate, making sure you get their consent prior to touching them or performing the assessment or procedure, and explaining what's going to happen before that touch happens are all very important things to remember whenever you're doing a physical assessment that involves the most intimate parts of individuals. From a diagnostics testing standpoint, male patients can benefit from complete blood counts, urinalysis, sperm analysis if they're having trouble with fertility or believe they're having trouble with infertility, culture and sensitivities on any types of discharge that you might see from the genitals, culture and sensitivity on urine, serum hormone levels to determine if they have low testosterone or other hormonal issues that are contributing to sexual dysfunction. PSA tests are often very common in older men. And then imaging tests that you can use are ultrasounds, CT scans, laparoscopic tests to detect certain types of problems. It's possible to need biopsies of the breast or genital area if there are abnormalities in those places. With female patients, these tests are very much the same. Adding in blood tests for sexually transmitted infections, pregnancy tests, pap smears. It is also possible from an imaging standpoint to include hysteroscopic exams. That's basically where they look inside the uterus with a scope to check out the endometrial lining. And then mammograms, of course, and biopsies if any of those things are needed. Patient education is a huge, huge intervention from a nursing standpoint when it comes to the concept of sexuality, sexual health, and any type of sexual dysfunction that people might be experiencing. It also depends on the way that you educate someone is going to depend on what their age is and developmental related changes that have happened or will happen in their sexual structure and function. So always remember who your patient is and where they are in the developmental cycle. Where are they on the lifespan? Stages in the human sexual response is something that we often want to educate patients about, particularly young patients, so that they know what those types of sexual response stages are. Information about methods of birth control for individuals, information on safer sex practices, sexually transmitted infections and how to prevent those in yourself and how to prevent transmitting those to other individuals. Teaching individuals how to do breast and testicular exams. Teaching them how to resume sexual activity after different illnesses or other health-related events. Pregnancy, surgeries, talking with patients about how particular conditions that they may have or how particular medications that they might be taking can affect their sexual function. A lot of the times patients do not know this because they may not be educated on it, and they may be also afraid to talk about sexual dysfunction that they're experiencing, but the fix might be something very simple. Talking with patients about diagnostic and medical and surgical procedures that can affect their sexual health, about adaptations that might allow patients who have physical impairments to continue sexual activity and remain sexually satisfied. So, patients who are paralyzed, teaching them about harnesses that can hoist them up so they can have genital to genital contact with their partner. There are lots of adaptations for people who have disabilities. And then referrals, obviously, to appropriate resources as the clients that you are talking with need those referrals. Nurses really have to examine their own feelings about sex and sexuality to ensure that you can establish a therapeutic relationship and stay in a non-judgmental mind frame and attitude while you provide care to these people. Nurses also should include the patient's partner whenever it's possible and whenever it's appropriate when you're doing patient education. Because by teaching both parties of the couple about the patient's condition, the nurse can help ease any feelings of shame or blame or discomfort that one party or the other was having that might have been hindering their satisfaction as far as sexuality is concerned, or their sexual experiences with that partner. So facilitating a better communication between those partners in regards to the problem can be really beneficial. So try to include the partner if it's possible and if it's appropriate. And if the partner is involved, you can also provide more effective instruction if there are adaptive devices that the patient might need, or methods that can help those partners in continuing or resuming a sexual relationship that's mutually satisfying to both parties. We can't talk about sexuality without talking about nurses who have to deal with inappropriate sexual behavior. This will inevitably happen to every one of you throughout your career, and so it's important to know how to deal with that. Nurses often encounter sexually inappropriate behavior when they're working. Sometimes it can be aggressive or it can be non-aggressive. It can come from a patient. It can come from a coworker. But we're going to talk about it from a patient standpoint today. So before implementing any nursing interventions with patients who have been making inappropriate sexual behaviors towards you, you got to determine where that behavior is coming from. Is the patient attempting to communicate a physical need to you? So do you have an elderly patient lying in the bed who has a catheter in and he is pulling at his penis? Maybe he's doing, while you're in the room, maybe he's doing that because the catheter is uncomfortable. So there might be a physical need. It might not be a sexual behavior directed at you. And once you determine that the behavior is truly an inappropriate behavior and not an attempt to communicate some type of physical need, it is important for the nurse to communicate that the behavior is not acceptable, that it makes you feel a certain way. You got to identify what type of behavior you expect out of the patient. You got to set firm limits, refocus the patient towards real concerns or fears and not the sexual behavior that he or she are portraying. Report the incident to the nursing instructor, the charge nurse, or the clinical nurse specialist, or whoever is the next up in your chain. and then clarify with that patient the consequences of what's going to happen if they continue that inappropriate behavior. So the worst thing that you can do in dealing with inappropriate sexual behavior from a patient, or anyone really, is ignoring that behavior, because that's going to increase the likelihood that that person will continue to engage in that type of behavior with you and or with someone else, and that they may interpret your lack of response as indifference to what they are portraying, or they may even decide that you approve of the behavior that they are portraying. So it's always important to address it and address it appropriately. Recognizing sexual abuse is something else that nurses also are responsible for doing. Nurses are mandatory reporters, which means that they are required by law to report all instances of suspected child maltreatment to the proper authorities. However, reporting suspected abuse for adults varies from state to state. So you have to know the laws of what state you're working in terms of how what the mandatory reporting requirements are for grown-ups. Sexual abuse often can manifest itself through emotional and behavioral signals that can be observed by the caretaker or the nurse. Children will often have avoidance or try to avoid, or they might have fear of being physically touched. Symptoms of depression and post-traumatic stress disorder might manifest themselves. Self-harm or suicidal behavior can often also be a behavioral sign. Difficulties in school, running away from home or school. Changes in their hygiene, regressive behaviors from a maturity standpoint, and inappropriate knowledge about sexual topics or behaviors for the developmental place in life that they are at the time. Those can all be signals that there may be some abuse going on. For adults, you may find that your patients are showing signs of depression, anxiety, post-traumatic stress disorder. You also can see self-harm and suicidal behavior in grown-ups, fear of contact physically, a disruption in their personal relationships with other people, and then a strong aversion to consensual sexual activity. So these individuals oftentimes will not want to engage in sexual activity of any kind. Lots of different ways we collaborate with other people to give therapy to individuals who are experiencing sexual difficulties. Surgery is one of those. We can use surgery to affect sex. There can be surgeries that affect sexuality. We talked about some of these earlier, like hysterectomies for women, prostate surgeries for men. Prostate cancer can oftentimes result in surgery, and that can in turn cause erectile dysfunction for men. Women who have ovarian cancer and have to have their ovaries removed surgically also may end up in early menopause before they ever expected to. That can affect their sexuality. Spinal cord surgery can impede sexual function. People who end up with bowel surgery, colostomies, those kind of things, can end up with body image issues, and that can lead to sexual dysfunctions for those individuals. For men who have erectile dysfunction, there are surgeries that treat that. We try to utilize surgery as a last resort to treat erectile dysfunction. We try to use the least invasive methods first, but there are different surgeries that can help treat erectile dysfunction, specifically implantation of prosthetic devices, reconstructing the penile arteries so that vasocongestion can occur easier, and blocking veins that drain the blood from the penis for the same purpose. Women can utilize surgery from a sexual standpoint to remove tissue around the vaginal opening or the introitus to help relieve pain during sex. The term for pain during sex is dyspareunia. And then obviously sex reassignment surgery for people who are transsexual. There are several types of pharmacologic therapies that are appropriate whenever you are dealing with people who have sexual dysfunctions. Hormonal contraceptives can be appropriate. Infertility medications for females. Male and female patients can also be prescribed hormone replacement therapies to help maintain hormone levels, and sometimes those hormone replacement therapies are used in the treatment of cancer as well, and not specifically in relation to sexual problems. And then there's a long list of non-pharmacologic therapies. There are mechanical or assistive devices for men and women who are experiencing problems in the sexual department, depending on what stage of the sexual cycle they're having issues with. We may need, for men, vacuum pumps for their penis to cause an erection. Women may need vibrators to increase their sensations of pleasure during sexual activity. I mentioned earlier harnesses for people who may have spinal cord injuries. And then nurses should be able to teach patients that there's nothing wrong with needing these types of assistive devices to make sure they're at the height of their sexual health. We don't have any problems utilizing a pill to take care of our blood pressure, and sexual health is a really important part of life. So being able to treat that and keep yourself as healthy as possible from a sexual standpoint is important, and nurses should be able to talk about that without feeling embarrassed or without causing the patient to feel embarrassed about it. Psychologic and relationship counseling is often another non-pharmacologic therapy that we use for people who are having sexual difficulties. So couples counseling, sometimes people need to be referred to a sex therapist. There are types of mindfulness techniques that are specifically related to sexual experiences. And then there's also something called integrated sex therapy, which blends different medical, behavioral, and cognitive techniques all together in one. And it's customized to that particular patient and their particular problem to help aid them in getting over that or increasing their sexual health. All right, so what about lifespan considerations? So if it's in children, we talked about this a little earlier in the slides, so we'll go over this pretty quickly. The first 12 to 18 months of life, a child does not understand the difference between male and female gender. The assignment of gender to a child affects how others interact with that child. So if you assign the gender of female to your child whenever they're born, then you will dress that child as a female, and in turn people will talk about how pretty she is. On the other hand, and it also affects what types of toys we buy them, and those kind of things. So on the other hand, if you have a child that you've assigned a male gender to, you're going to buy that child male type clothes, and people will respond to that child in the sense that they are a male. So for Christmas, they get trucks and cars instead of dolls. So that's what this means about how assigning a gender to a child affects how other people interact with them. But between 12 and 18 months, the child can differentiate between themselves and other people, and they begin to develop an identity as either male or female. Self-image at this time is shaped by external beliefs, expectations, and attitudes. So the external beliefs, expectations, and attitudes of other people towards that individual. And learning more about their physical bodies and self-exploring, including their genitals at this time in life. But it's not for a sexually pleasing reason. Between the ages of 1 and 3, kids have a more purposeful body exploration, more purposeful masturbation, and they can even have some orgasmic responses at this time. By the ages of 1 and 3, children often identify with their own gender. So they either identify themselves as a boy or a girl. They have early awareness of their anatomical differences. They know little boys look different than little girls. And then as they grow and become between the ages of 4 and 5, they have a fuller sense of their self and who they are, and they will begin to explore the body parts of other children their age as well. Around 8 or 9, kids will become concerned about specific sex behaviors, and they might approach their parents with concerns about sexuality or where babies come from or what does this word mean. And it's important to make sure that you give direct answers and that the message you portray is accurate. The family role is major in shaping an individual's view of sex and sexuality. So the development of gender identity, body image, a sexual self-concept, and your ability to have intimacy is influenced greatly within the context of the family you live in. Relationships and gender expression and expectations of others and yourself are influenced by the family. Your parents' reactions to the questions that a child asks, or even that child's normal genital exploration, can affect how that child feels about their sexuality into their adult years. So if you have a child who is normally exploring their genitals at a certain point in the lifespan and the parents punish the child for that, it can cause feelings of guilt, embarrassment about their sexuality, and that can persist into adulthood. So it's really important for parents to answer questions very honestly using the correct name for body parts. And it's important for nurses to provide parents and children with the opportunities to express concerns and ask questions. Encourage parents to discuss basic information with their children. This is a really hard topic to talk about with your kids. And so one suggestion that you could make is that it can be really helpful to provide reading materials to your children about sexuality and sexual issues, and then discuss it with them days or even weeks later. Sometimes that's important for parents, and that helps them start the conversation. For adolescents, so we're talking about kids roughly 12 to 18 years old, these guys are having a rapid and dramatic change in relation to sex and sexuality. Their hormones are beginning to kick up and ramp up. Girls start menarche and boys have spermarche, which means they become fertile at this point. They start to have relationships and they become interested in other individuals from a sexual standpoint at this point in time. A lot of it because of hormones, really. Their peer groups are extremely important during the adolescent period. Nurses should approach teens related to how they are from a cognitive and a social development standpoint. Nurses need to be non-judgmental. They need to focus on the adolescent and not the problem, if there's one presented. It's important to ask the parents to leave the room for part of the history, maybe when you're doing the interview, because oftentimes adolescents will not talk about these things in front of their parents. Make sure that you establish a therapeutic relationship with the adolescent, because everything that is discussed with the nurse should be confidential unless it is going to cause harm to the patient or another person. And the patient or the adolescent should be reassured that what they tell you is going to remain confidential and that you're not going to be blabbing to their parents afterwards. Nurses may have to start the conversation about sex and sexual organs with adolescents. So it's important to use specific language, words that the adolescent understands. Ask the teen for questions that maybe they have about sex. And don't be embarrassed or judgmental about language that they might use to describe things. Just roll with it. During the physical exam for adolescents, much like for adults, it's important to make sure that you do the interview first, establish a therapeutic relationship, let them know what's going to happen, have someone there with you in the room, be very careful about the way that you touch intimate areas of the body. And the only thing different as far as the physical exam is concerned is that at this point for adolescents, you are going to be assigning a sex maturity rating based on those Tanner stages that we talked about earlier. Pelvic exams on teen girls are not typically done unless there is a problem. There's a necessary reason to do the pelvic exam. And if you have to do a pelvic exam on a teenage girl, the only thing different about that is you want to let her hold the speculum, show her how it works, tell her exactly what's going to happen so that she isn't fearful. Always have a chaperone present. I'm going to let the clock stop. As far as education is concerned for adolescents, information about body changes that they might experience, particularly those that are going to happen in the next few months ahead, is important so that adolescents know what to expect. Teaching them about contraceptives and sexually transmitted infections, because as we know, children, or I guess they are children, adolescents are experiencing sexual encounters earlier and earlier in life now. Discussing the importance of healthy dating relationships. So what does a healthy dating relationship look like? And screening for signs of dating violence, not just for the victim, but also being able to recognize behaviors that might be indicative of someone who could potentially become a perpetrator. So, in educating educating adolescents about both sides. What does it mean to be a victim, and what does it mean to be a perpetrator when we're talking about dating violence? For young adults, So we're looking at individuals now who are between about 18 and 40 years of age. Sexual identity usually is fully established by the mid-20s. And the majority of this population, young adults, engage in regular sexual activity with someone. Reproductive health issues are the most common sexually related issue that we see as nurses in the healthcare setting for this population or this part of the lifespan. Because at this point, these people are getting married, they're establishing themselves as couples, and they're wanting to get pregnant. So giving, or maybe they're wanting to not get pregnant. So giving them information about preconception counseling or pregnancy prevention, educating them about the treatment of sexually transmitted infections, how to prevent those infections, and then referring them to further medical or psychologic care if they've got compulsive behaviors that need to be corrected from a sexual standpoint. Pregnant patients are also considered part of the lifespan, and it's important to be able to educate pregnant women that sexual activity is usually safe for the woman and the fetus. This is often an anxiety-laden time for couples who are pregnant in regards to sex, and so it's important to talk about that with these individuals. The only time really that sex or sexual activity is not safe for pregnant patients is if that patient has experienced some vaginal bleeding or leaking of amniotic fluid, if they're having cervical issues, so their cervix is not wanting to stay closed, if they have placental abnormalities, if they've had a history of miscarriage, preterm labor, or premature birth, or if they're carrying multiple fetuses. So any of those things can be affected and have a negative outcome whenever we're talking about sexual encounters. But otherwise, it is usually very safe for pregnant women to have sexual intercourse and sexual experiences with their partner. The patient, hey, can you take your, Earl, can you go in there with your Batman? I'm almost done. Thank you. The patient who is pregnant might report a lower desire for sex during pregnancy, and that's normal, and it's normal to let them know that's normal. Yes, buddy. Okay, Batman. Love you. Pregnant patients might find sex as uncomfortable. Just because of the ways that the body changes and how the fetus will sit in the pelvis sometimes. So the nurse can suggest different types of positions and alternative sexual activities that are different from just sexual intercourse. Positions that will get the belly out of the way are often more comfortable, so side-lying positions, and that's a common one. In the postpartum period, it's important to educate pregnant patients to avoid vaginal sex for at least 6 weeks or more until they're cleared by their physician or their healthcare provider, because that gives the vagina time to heal after having a vaginal birth. Physical and hormonal changes also can make sex uncomfortable for pregnant patients. And we want to be able to include partners in this education if it's appropriate and possible. because they also need to hear that it's not because their pregnant partner doesn't look at them as desirable anymore, but it can really truly be just related to hormonal changes that cause a decrease in desire. Middle-aged patients are patients that are between 40 and 65 years old, and their age-related declines in hormone production will trigger the climacteric. They will have, because of this, alterations in their sexual function. Women experience menopause, usually between 45 and 55 years old. And men have a really more gradual and less dramatic climacteric than women. It's very noticeable in women because of menopause. But just like in adolescence, where it's a less dramatic entrance into puberty than it is for girls, it's the same in middle-aged patients who are having climacteric. It's more gradual and less dramatic in men. For psychosocial changes during this age, these guys they have new social roles. The end of their career is approaching, so they're close to retirement age. Their children leave home. And when social roles change and the way you see yourself as a person who contributes to society changes, your role in the home even changes, it might be very difficult to adjust and move forward in sexual relationships with your partner that are different than they were before. So, the couple who are empty nesters, who have been working really hard to get their kids through high school and graduated. Now those children, the focus was children for so many years and not each other. Now those children are gone, and when you come home from work every day, you're staring at a person that you might not feel like you know anymore, and that can affect their sexual relationship. So it can be difficult to adjust. Those people might need a little counseling. But again, communication is really key. And then for older adults, yeah, that's your cousin. For older adults, their interest in sexual activity continues well into old age. But older adults really will define sexuality a lot more broadly than younger adults and middle adults even. The little block. There's a little block. I'll help you. I'll help you 2 minutes. I got 2 slides. No, wait, no, not that block. No, you're going to electrocute yourself. Stop. I will help you in 2 minutes. Play Batman for 2 minutes, and I'll help you, okay? Go watch TV for 2 minutes, and I'll be right with you. Okay. So, I'm sorry, y'all. So older adults will define sexuality a lot more broadly than their younger generations. Giving roses to somebody can be part of your sexuality, whereas some of the younger generations really see that as really more of a physical intimacy between each other. Alterations in sexual function begin to start to really show up because of the aging process. For women, they enter into menopause, their vaginal secretions will diminish, their vaginal walls will thin. Those things will lead to dyspareunia, which is painful sex, and vaginal dryness. So encouraging lubrication is an important educational thing that you can talk to women about. Breast atrophy. Again, dyspareunia is difficult penetration, so you may have to teach these women to actually guide their partner's penis into the vagina. They may have to help with that. Men have fewer sperm, but men are often fertile throughout the lifespan. However, in older age, they take a longer time to achieve erection and ejaculation, and they often need a lot of manual stimulation or direct stimulation to become aroused and to achieve that erection. Sometimes it's not as erect as it was when they were younger. Chronic pain and osteoarthritis, cardiovascular disease, and diabetes can also negatively affect sexual activity. And these older adults also benefit from teaching related to sex, but they might be reluctant to raise that topic with you. In general, if an older adult can climb 2 flights of stairs or walk at a rate of 2 miles per hour without chest pain or shortness of breath, then they should not have any cardiac problems during sexual intercourse. Patients with less stable vital signs should not be positioned on top. And heart failure patients who develop fatigue or shortness of breath will be more comfortable in a semi-reclining position or lying under their partner during sex. And it's important to teach these individuals those types of things. So thank you for listening to the Sexuality Lecture Part 2. And see you guys in class.